Insights from the world's best medical minds. You are watching therightdoctors.com.
Good evening, viewers. I'm Dr. Sharat Chandra. I'm a senior cardiologist at Hyderabad, working at Virinchi Hospital and Indo-US hospitals. I was editor of Indian Heart Journal in the years 2012 to 2014, and I was president of Cardiological Society of India in the year 2018. I'm going to talk to you today about the cardiovascular manifestations of COVID-19. You are at rightdoctors.com, India's leading medical knowledge platform. As you all are aware, this COVID-19, due to infection by coronavirus 2, affects many organs in the body, but one of the most important ones after lung disease, the affection of the cardiovascular system. Cardiovascular patients occur in 8 to 12% of all the patients of COVID-19. The pathophysiology of cardiovascular affection of the by this disease can be due to direct damage to the cardiac muscle cells, because the cardiac muscle cells, like the endothelium, have got plenty of ACE2 receptors. It is through the ACE2 receptors that the virus enters the cardiac muscle, or for that matter, any muscle, and therefore it is very likely that the cardiovascular system is affected. The other mechanism, or probably the more important mechanism, is the hypoxia, which is induced by the lung disease. And due to severe hypoxia, the cardiac muscle can occur. The immune-mediated cytokine storm is another very important mechanism by which the heart is affected. As you all know, cytokine storm plays a very important role in the pathophysiology of the COVID-19, and because of this, many cytokines are released into the blood system, and these cytokines can affect the heart. Another of the cardiovascular system getting damaged can be due to the thrombosis. The thrombosis is a very important manifestation of the COVID-19 in general. One can find thrombus in blood vessels in the periphery, in the lungs, in the alveoli, and sometimes in the coronary. So by all these different mechanisms, most important of which probably is the immune-mediated cytokine storm, or the hypoxia-induced cardiac muscle injury, and probably thrombosis. The direct damage to the cardiac muscle cells is proposed, but there is no clear proof to that. The clear patient that the myocarditis can occur in these patients has not been clearly demonstrated, has not been taken place, and it is only a proposal that there can be myocarditis, but nobody clearly demonstrated it. In fact, the European Society of Cardiology clearly says that there is no proof. Some patients subjected to endomyocardial biopsy, and of course some autopsies were also done, and none of them have shown clear evidence of myocarditis per se. The pattern of presentation of this disease can be one of the two. The first one is the cardiac injury can manifest itself as an early rise of troponin, along with other biomarkers, as I said, like ferritin, D-dimer, LDH, interleukin-6, which are all part of the cytokine storm. If you look at the survivors and the non-survivors, the troponin levels can be different, and troponins form a very important part of the prognostication of COVID-19. For example, the survivors, the troponin levels rise from 2.5 picograms per ml at day 4, let us say. It can at the most go to 4.4 picograms per ml in the survivors. On the other hand, in the non-survivors, there is a continued increase of the troponin from 8.8 at 4 days to 24.7 at day 7, 55.7 at day 13, 134 picogram ml on day 19, and a whopping 290 picogram per ml on day 22, the non-survivors. So you can see here that the troponins are a very good way of prognosticating these patients, and also the troponins can give you a diagnosis that cardiac injury has occurred. The second pattern of presentation is slightly delayed, and this presentation is more like severe coronary ischemia or like myocardial infarction pattern. There can be marked ECG changes, there can be ST elevation, there can be ST depression, chest pain can occur, there may be LV dilatation, LV systolic dysfunction, and along with all this, the troponins also can rise. And along with the troponins in this syndrome, the NT-proBNP also is elevated. And this particular second pattern behaves more like stress cardiomyopathy, or some of us call Takotsubo syndrome. And the second pattern, if given adequate therapy, can lead to actually complete recovery of the heart function. The manifestations of COVID-19 cardiovascular system disease can be treatment of heart failure newly, or worsening of the pre-existing heart failure in patients who already have a cardiovascular disease. In one study, 52% of those who expired had the evidence of cardiovascular manifestation in the form of heart failure, and 12% of patients recovered and were discharged. So among the patients who died, the incidence was 52%, and among the patients who recovered and discharged, the incidence was 12%. So heart failure development is an important prognosticating factor also. There can be arrhythmias, which can be supraventricular or ventricular arrhythmias, and the overall incidence of arrhythmias can be 16.7%, and among those with severe illness, it was demonstrated as 44.4%, and among milder cases, the incidence is 8.9%. As I said earlier, the condition can present itself as acute coronary syndromes. There are a lot of patients who were taken to the cath lab, angiography was done, and it was found that there are no critical flow limiting actions, and the patient were brought back to the intensive care unit. And sometimes this procedure of doing angiography in a sick patient can be even troublesome for the patient and can worsen the patient's condition. Therefore, one has to be very cautious when one decides to take the patient to the cath lab. And in the presence of positive COVID-19, the threshold for taking up the patient for an urgent angiography intervention should be very high. The patient can also present as a case of cardiogenic shock and requires all the supports one can give, namely inotropes and ECMO or IABP and so on. So the presentations can be development of new heart failure or worsening of pre-existing heart, presence of arrhythmias, presentation as acute coronary syndrome or even cardiogenic shock. And many patients, these 3-4 of them can be combined in the same patient at a time. There is a great association of comorbidities in relation to COVID-19. Comorbidities of cardiovascular system, there can be hypertension, there can be diabetes, there can be coronary artery disease, CVD. And if you take these patients, the overall of associated comorbidities is 24%, while in those patients who are on ventilators or died, the incidence is 58%. Hypertension association is 15%, while in those patients who are on ventilators, it is 36%. Diabetes similarly 7.4% overall versus 27% in the sick patients. Coronary artery disease is 2.5% overall versus 9% sick patients. So it shows that there is a strong association with comorbidities and COVID-19, and especially it is a very important, they are an important association with more sick illness. The case fatality rate also increases with comorbidities. The case fatality rate with hypertension is 6%, with diabetes mellitus it is 7.3%, and if this cardiovascular disease already existing, namely earlier myocardial infarction, patient has undergone procedures for the heart, and patient is in atrial fibrillation, etc., the incidence case fatality rate can be 10.5%. As I mentioned earlier, prognosis is clearly decided by many things, among which is presence of cardiovascular disease, comorbidities, and the elevated levels of troponins. Now, the management mostly is on general lines, like supporting the patient with oxygens. The patient may be given ventilatory support. A lot of importance is given in this particular condition to ventilation in the prone position. Treat the patient even if you are not doing ventilation. Even putting the patient simply in prone position also helps these patients. treat the patient if there is heart failure with various heart failure medications. You may have to give inotropes in case the patient has got hypotension. Usage of IABP, etc., are recommended in case of need, in the presence of severe hypotension. One important thing is monitoring of PA pressure in these patients. If you take the patient to the cath lab for any reason or primarily for this purpose, one may have to monitor the PA pressure and use that knowledge for giving the patient fluids or using the various other devices for deciding the therapy. Now, some important trials have been done in the recent times, and let me talk to you about two important trials. One is the recovery trial, which is published very recently. It is a trial done in the United Kingdom. They studied 11,000 patients. There were 6 arms, one of which studied the usage of convalescent plasma, that is plasma which is patients who have completely recovered after COVID-19. Another arm tried dexamethasone oral, tried hydroxychloroquine, then azithromycin, then tocilizumab, which is an interleukin-6 receptor blocker, which is very useful in cytokine storm. And of course, the last arm tried lopinavir, ritonavir combination. These are drugs used in HIV. Now, recently the results of oral dexamethasone are published, and you all know that this is about a big backstory. And dexamethasone given in small doses has shown for the first time a drug that can produce a reduction in the mortality in patients of COVID-19. This particular arm showed a 1/3 reduction in mortality in patients on ventilator and 1/5 reduction of mortality in patients who are on oxygen. Another trial that is known recently is the Solidarity trial. This, of course, is a multinational trial sponsored by WHO. Multiple centers are doing this trial, and it's a very large trial. And there are 4 arms. One tried remdesivir, another tried lopinavir, ritonavir, as I mentioned. Another arm tried again lopinavir, ritonavir, along with interferon beta. And the last one, of course, tried the hydroxychloroquine. And with the recent publications that has come showing that are suggesting that there is no advantage of using hydroxychloroquine, this arm was stopped. You know, there's a lot of controversy about this. 2 organizations brought a lot of data. People have contested the veracity of this data, and there's a lot of criticism on this. Many believe that hydroxychloroquine still helps these patients. A lot of physicians themselves run hydroxychloroquine to avoid possibly, hopefully, severe manifestations of COVID-19. And 2 drugs have recently been approved in India, and one is remdesivir by Hetero Drugs, which is going to market, and another is favipiravir by Glenmark. Overall, if you say, allow me to say, there is a reduction in the new cases as well as severity of the disease in many countries which suffered initially greatly, like Spain, Italy, UK. As I was told, and we read also on the internet, that there is a reduction of mortality as well as in ventilatory support among patients, among the new cases in various countries which I mentioned. It is likely to happen in India too. This may take time. Maybe it will need time till another 2-3 months have to pass off before India will see some reduction in the incidence and severity of the disease. So there is light at the end of the tunnel, and I hope that we will see the back of this disease sooner than later. Thank you very much.
Insights from the world's best medical minds. You are watching therightdoctors.com.